Good evening, ladies and gentlemen. It's my great pleasure to be with you at the 4th International Lipid Expert Panel webinar, which today evening will be completely dedicated to case series of patients with severe hypercholesterolemia, dyslipidemia, and lipid disorders. The main aim of today's webinars is to give you the real-life practice and real-life data how to manage with patients, which sometimes is associated with the individualization of the therapy, obviously based behind it needs to be guidelines we use in our everyday clinical practice, but sometimes these cases will show you that it is not so easy to manage patients with hypercholesterolemia. So it is my great pleasure to be with you. I can only say you that there is almost 700 participants on today's webinar, so it is great to see you all. And these are people from all over the world, so I would like to kindly welcome all those from Europe, from Northern and Southern America, as well as those from Asia and Japan. It is my also great pleasure to be with my great colleagues and friends, great experts in the field of preventive cardiology and lipid disorders, atherosclerosis, Professor Margus Viigima from Tallinn, Estonia. Margus, it is a great pleasure that you are with us. Professor Gustavs Latkovskis from Riga.
My pleasure.
It is a great pleasure that you are with us, and Professor Gyorgy Paragh from Debrecen, from Hungary. It is indeed my great pleasure that we all here will be focused to present today the very spectacular cases that hopefully will help you in your everyday clinical practice. So I don't want to delay the start of this webinar, and I would like to kindly invite Professor Margus Viigima to start with his presentation. So Margus, the floor is yours. Thank you again that you are with us.
Thank you very much, Maciej. Good evening, dear colleagues. It's a great pleasure to have this talk on the series of webinars, and I'm really happy that that ILEP has organized very, very interesting and very practical webinars, and thank you, Maciej, for this invitation. So my task is talk about the primary prevention of cardiovascular disease with a elevated LDL cholesterol patient. So this is where all our story starts. Yes, this my patient, my very recent patient, is 52 years old male. As you see, he's very sportive, normotensive, no diabetes, non-smoking. And the only problem is that the father died of myocardial infarction, and that's why he started to think about elevated cholesterol, which was already many, many years. On the other hand, mother is healthy, and they age 74 years, and he is the only child. As you see, LDL cholesterol was 4.1 to 3.8 millimoles per liter, which is elevated, but not so much. And the patient has been following lifestyle intervention, and the diet is very good. HDL cholesterol is high, as you see here, and the only medication until now was omega-3 fatty acids, and not a very irregular basis. So next slide. So what should we do? As you see here, the recommendation in this patient, it's a low risk or just on the border of low and moderate risk, is that we should consider lipid-lowering therapy. The same next is with a moderate 1 to 5 risk of cardiovascular disease. That's European guidelines. American guidelines, the most newest American guidelines, as you see, the same risk The risk calculation in US, as you know, this is a morbidity risk, but anyway, we have to calculate the risk and the benefit and in which patient, in which risk category in primary prevention to start lipid-lowering therapy. The 2B class of recommendation, class 1 recommendation, or high risk patient class 1 recommendation. But very much is depending on the calcium score. That's the same in American guidelines and also in European guidelines. Calcium scoring is a very important aspect, but there are also other important aspects. Now, next slide brings us what did I do? We have to, and I did, reclassification of total cardiovascular risk for defining eligibility for lipid-lowering therapy. Because the patient was not very interested in lipid-lowering therapy at all, as you may imagine. And I did biochemical additional investigation. That's so-called atherosclerotic panel in my hospital, which I started with some of my coworkers. And surprisingly, or maybe not so surprisingly, we have detected lipoprotein small a extremely high level, which is 118 milligrams per deciliter. And in the new guidelines, as you know, there are 180 milligrams per deciliter. Is equal. The risk equals to the familial hypercholesterolemia. Also, what we did also some other biochemical markers like homocysteine and cystatin C, others, but nothing more serious was found. But calcium score was 78 Agatston units, which favors to statin therapy. If it's more than 100, we should start statin. If it's between 1 and 99, it favors statin therapy. So it's getting more serious. But we did also the polygenic risk score based on the cardio compass. I will come back later about this cardio compass. And that was a high, 1.4, high risk. So it's getting more serious if we take into account additional investigations. And I started medication with rosuvastatin 40 milligrams and ezetimibe 10 milligrams. So the patient has not yet, he's coming to me now in 2 weeks, but I know that lipoprotein small a, and we all know it will not be changed with rosuvastatin, and maybe we should also start PCSK9 inhibitors. That's 2B recommendation in the European guidelines. In case if we do not succeed with rosuvastatin and ezetimibe, but we will not succeed with lipoprotein small a for sure. So, and the cardio compass risk assessment, you can see here how it looks. This is the mobile version, but and it's Estonian language. But anyway, you can see there is a intermediate risk, and there is a high risk on the right. And as the risk gets higher, more than 1 is already quite high. It's a high risk. But 1.4 is very, very substantial additional risk, and which is nice in cardio compass is that the patient and also the GP and also the cardiologist can see the risk without genetic markers and also with genetic additional risk. And this lower curve shows the mean value of risk in the population. And it's very nice to play to show if the cholesterol is going down, if patient is quitting smoking, or how the risk will be changed. That's a very nice tool to use. Now, what should be really the goal of lipid-lowering treatment in this patient? We can discuss later on, but it looks that 2.6, it's very mild treatment goal, because we know that the patient has already atherosclerosis. And I can tell you more. We did also CT scanning of the coronary arteries, and we found 25 to 50% stenosis in several arteries. So it's much more serious patient really. And how important are genetic risk score? These are Estonian Genome Biobank data, and you can see that in high polygenic risk, it's myocardial function cumulative risk is much higher compared to the non-high genetic risk score. And same is true for males and females, and also for cardiovascular mortality as well. So we have now in Estonia 250,000 subjects in the biobank, and the total number of inhabitants in Estonia is 1.3 million. So it's and the goal is to have half of the population included next years. Here you can see the nice paper by Eric Topol and co-workers in Nature Review Genetics, showing that polygenic risk is very important, is as important as high cholesterol, smoking, and systolic blood pressure. And that's exactly what we have found in Estonian cardiovascular personalized prevention project, which we are running in Estonia. Polygenic risk is same, approximately the same value for cardiovascular risk compared to the high cholesterol. Some studies have shown that highest 5% of polygenic risk, these subjects having the same risk as familial hypercholesterolemia patients. So it's really very important. But there are some doubts. There are very recent papers in JAMA, just recently published. They are very nice papers, by the way. The first one from UK Biobank, and the second one from two different subject settings from US, showing that polygenic risk score adds little bit accuracy, but not too much. But the main issue here is that the patients here are quite aged, so their average age is something like 60, 65 years. But we should start polygenic risk scoring in a much younger age to prevent cardiovascular disease, or to postpone it, and that's what should have been done. And here you can see really there is some importance of polygenic risk score. You can see non-cases of cardiovascular disease and cases of cardiovascular disease. So with a higher polygenic risk, there are more cases, but not so much, not so much more. But the main reason is the age of the subjects studied, because in this 60-year age, we are a bit too late to talk about polygenic risk. We should think much earlier. But what is good, always my colleagues asking me, why are studying cardiovascular genetics? What can we get in real life? And these are quite recent papers published in Circulation or simultaneously about polygenic risk score and cardiovascular benefit from PCSK9 inhibitors, both alirocumab, evolocumab. On the left panel, you can see nicely concerning the alirocumab how well is doing PCSK9 inhibitor in high polygenic risk score patients. And same is true for evolocumab. You can see on the right panel, very huge difference in the high polygenic risk group, but almost no difference in low risk patients. So this is important, and also that similarly has been shown some years ago with statins in Jupiter, ASCOT primary prevention studies, also in secondary prevention here, and prove it. Now the last slide about Estonian randomized clinical pilot study we are running, which is focused on health impact and proactive prevention strategy for cardiovascular diseases in subjects with high genetic risk. And we have divided those random subjects into two groups. One is a control group where just ordinary the management is like it is in everyday healthcare, and the patient don't know about the extremely high polygenic risk, and also the GP is not aware. But in the intervention group, they both are aware, and family physicians are more detailed. They are more focused to risk cardiovascular risk management, and we are also we are looking for a decrease of cholesterol, blood pressure, body weight, but also we are going to see how the treatment compliance has been changed in those patients, and what the cost effectiveness analysis show us. And we do hope that this will introduce the new era of cardiovascular prevention, especially in primary prevention of cardiovascular disease. Thank you so much.
Thank you very much, Margus, for beautiful presentation. It might be really not so easy to diagnose patients in primary prevention, taking into account his risk, because as I have noticed, this patient at the very beginning could be considered as moderate cardiovascular risk without those data from CAC score, without those data on lipoprotein little and polygenic risk score. And please have noticed that if we have additional measures, especially based on this, on the information that in the family history there was a death of the father at the age of 57, and probably the symptomatic issues of these patients, you've decided to make the lipoprotein little, which was very high, polygenic risk score, which was 1.4, and additional CAC score, which was 78. So altogether, this patient was at a very high cardiovascular risk. So it is a beautiful slide in order to see that in primary prevention, it is not so easy to have the very good risk stratification of our patients and their suitable treatment. But I believe that we will have the opportunity to discuss it further in our discussion. And now I don't want to wait any longer, because I am very sure that Gustavs have just prepared a beautiful cases, and Professor Gustavs Latkovskis. Gustav, the floor is yours. Thank you very much.
Thank you very much, Maciej, for inviting me this very interesting webinar. So I've prepared a few cases. So these are my disclosures. The first case is a male patient whom I saw first last year in 2019, early in February, when he was 57 years of age. At that time, the history was that at age 42, he had 3-vessel disease in coronary arteries diagnosed, and he underwent coronary artery bypass grafting. Then we did the PCI of his left main circ and obtuse marginal with 3 drug-eluting stents because of the 1 graft occlusion at age 51. And since we saw that his LDL cholesterol was 1.86, he was switched to rosuvastatin 40 and ezetimibe at age 53. So he actually had, at that time, in terms of the guideline recommendations, the optimal result. His LDL cholesterol was below 1.8, which was 1.7, and non-HDL cholesterol was also seemed optimal. Here you can appreciate his coronary arteries. This is his circ. This is after stenting. This is his left coronary artery. This is native right coronary artery. This is the bypass graft to his right coronary artery. But the interesting thing was, unfortunately, that despite the fact that he was very compliant with all the treatments and recommendations, and he was really taking these drugs on a regular basis, and his LDL cholesterol was 1.7 for 2 years. Nevertheless, he developed inferior QMI at age 55, and that was occlusion of his vein graft in the right coronary artery. So he had PCI done in his right, and here I just pointed out where the atherothrombotic event happened afterwards. I don't have those slides when actually this occlusion happened, because that was in some other hospital. And even more regrettably, he had a progression of his carotid stenosis, and he actually that led to carotid endarterectomy at age 55. Here you can appreciate his carotids, and namely left carotid artery was severely stenosed, and that's why he underwent this surgery. So when I saw this patient, I asked myself, well, what is going on with this patient? What is the mechanism why he has this atherosclerosis progressing? Is this not enough lipid lowering? Is this lipoprotein little a? Is this inflammatory process? Is this metabolism? Or should I tackle more his coagulation cascade and adding maybe rivaroxaban to his aspirin? So when I reviewed his risk factors, nothing was really remarkable. His hypertension was mild and well controlled. He was non-smoker. He was physically active. He was just a little bit overweight. He was non-diabetic, slightly increased insulin resistance. He was taking the other drugs. But what was very interesting, unfortunately, his family history. So his family history was that his father developed coronary artery disease at age 40. And later on, he developed at age 60 myocardial infarction. All three, his siblings, underwent either myocardial infarction or some kind of coronary revascularization, really at early age, 50, 55. So he was really very anxious about the fact that despite taking all these drugs, the disease really is progressing. So what can I recommend to him? And that was last year early. So these were the actual lipid levels at that time. And from today's perspective, we know that half year later, the new European guidelines came out, which recommend that the LDL cholesterol levels should not be less than 1.8 in secondary prevention, but less than 1.4, and at least 50% reduction should be achieved. However, these new guidelines also point out that in those patients who have repeated vascular events within 2 years, with a class 2B recommendation, they should be achieved. It is recommended to consider going for lower goals, namely LDL less than 1.0 millimoles per liter. I also ordered some additional tests. So it turned out that his inflammatory activity was pretty low. It was 0.5. But what was most likely one of the explanations why he has such aggressive atherosclerotic disease was obviously his very high lipoprotein little a. Although I should say, I believe, and I think it's very interesting what Margus just explained, that probably there are some other genetic mechanisms responsible for that, which are maybe not even lipid related. Nevertheless, we discussed with this patient the further options, and since it was atherosclerosis progression, not just the thrombotic events, we decided that we start evolocumab, PCSK9 inhibitor, 140 milligrams subcutaneously every 2 weeks, and I recommended to do the first follow-up testing in 4 weeks. So this patient was a little bit impatient in terms of the lipid analysis, he was very anxious to know how he reacts to this subcutaneous injectable drug. So he did the first analysis already at 1 week, and to surprise to him and me as well, we already noticed that there was very substantial reduction of LDL cholesterol down to 0.40. So I looked up the literature and discovered that yes, it has been described in the literature that within 2 weeks, we already have a very good result. The second question patient asked me was, well, should I be stopping the rosustatin 14 ezetimibe? And my answer was no. You should be happy about this very low LDL cholesterol because so far we haven't seen any adverse side effects from such a low LDL cholesterol. So we should be really happy that it is really low. And as a matter of fact, I saw this patient just earlier this week at the 18 months follow-up. And his LDL cholesterol has been pretty stable, somewhere around 0.4. And also remarkably, his lipoprotein little a has decreased to 112. Of course, it is still pretty high, but on the other hand, it is, of course, much lower than it used to be, which was almost 108. And as Professor Viigima already previously mentioned, that is equivalent to FH risk. So, and so far, patient has been currently uneventful. So the take-home messages for this case that I would put forward is, first, LDL cholesterol 1.7 is really not low enough for quite many patients to ensure effective secondary prevention. We should follow the new guidelines regarding the very high-risk patients that should be less than 1.4 and in extreme cases less than 1.0 millimoles per liter. We should not be afraid of very low LDL cholesterol levels. And PCSK9 inhibitor is really effective and well-tolerated add-on therapy. And I would stress add-on, just not replacement therapy in such extreme risk patients. The second case I would like to share is also another patient that I saw just this week, but I had already seen him before. He's at the time we first saw this patient, he was 28 years of age. His family history was that he had a familial hypercholesterolemia diagnosed at age 28. He was not treated with statins before or any kind of lipid-lowering therapy. At that time, LDL cholesterol was 7.4 millimoles per liter. He was mildly obese, non-hypertensive, asymptomatic. We tried to do the coronary CT scan, but because of the high heart rate, it was not possible. And as a matter of fact, this patient was very, I would like to say pushy, but in the positive way. So he insisted that he would like to do the invasive coronary angiography, which we were not sure that he should be undergoing it, but nevertheless, that was done. And to all of our surprises, we discovered that his coronary arteries were really severely diseased because actually his stress test didn't show a very severe ischemia or any kind of ischemia. So indeed, as you can appreciate, in the left coronary artery, there's lots of cholesterol and plaques and diffuse coronary atherosclerosis, and even worse, it seems, in the right coronary artery with ramus posterolateral branch being severely affected. So we, of course, recommended him to start the lipid-lowering therapy even more aggressive, but unfortunately, he was not really tolerating it well. Rosustatin 30, we had to downgrade to lower doses. We tried to add the ezetimibe, which he didn't tolerate either. He had some muscle pain. Actually, this patient has some also a history of cerebral palsy from the infancy. So that was also one of the facilitating factors, perhaps. So we checked for the vitamin D, which was low, so it was corrected. The thyroid function was normal. We tried to use, based on some reports, coenzyme Q10, which didn't really help much. So we tried to go very slow. Rosustatin gradually was increased to 10, 20 milligrams twice daily, then ezetimibe half a tablet several times per week, and then 5 milligrams twice a day. And as a matter of fact, as a follow-up visit this week, I was happy to see that he's currently really taking rosustatin 40 and ezetimibe 10, but the problem is that LDL cholesterol is still pretty high. It's 2.38, so it's well above the goal. So we discussed with him the treatment of PCSK9 inhibitor. So take-home message from this is gradual increase of lipid-lowering therapy doses is possible in some cases. when patient initially doesn't tolerate them well. However, in many patients, this is not possible, and PCSK9 inhibitor is indicated. And just very briefly, the very last case is 48 years old, female patient who has also FH, 3-vessel disease since age of 33. She has undergone 7 PCIs, including one of the PCI of CTO of her right coronary artery. And and even on top of the atorvastatin, she had LDL-14. She was switched, of course, to rosuvastatin 40 and ezetimibe 10, and nevertheless LDL is 11. So she is currently considered for PCSK9 inhibitor. And I would like to end with a very positive news that we got just recently from July 1st. We have approval of reimbursement of PCSK9 inhibitors in revascularized patients who have indication for secondary prevention if LDL cholesterol is above 3 on maximal tolerated statin ezetimibe dose, and it's 100% reimbursement. And in secondary prevention without any previous hospitalization, 50% reimbursement for FH patients, which, by the way, we have a separate diagnostic code for. So thank you very much for your attention.
Thank you very much, Gustavs, and my great congratulations on your reimbursement of PCSK9 inhibitors in Latvia, because in Poland we still have been fighting in order to have the possibility of treating ACS patients with PCSK9 inhibitors. We have only drug program for FH patients. Altogether, I believe these were very educative cases, especially that the one on statin intolerance and gradually up titration the dose, because we all need to remember that 95% of patients with initial symptoms, muscle symptoms on statin therapy still might use statins if we are patient with our patients and still have time in order to gradually increase the dose. Okay, but I believe still that there will be a lot of time in order to discuss it further, because I believe all those cases are beautiful, and thank you very much. And it is my great pleasure now to invite Professor Gyorgy Paragh from Debrecen, from Hungary, to present his cases. So Gyorgy, it is a great pleasure that you are with us. So the floor is yours. Thank you very much.
I welcome everybody. I thank you for your invitation to this meeting, and I would like to present those patients who has a heterozygous familial hypercholesterolemia with diabetes mellitus. How can I move the slides? Okay. 45 years old male patients whose diabetes started 5 years ago, and family history positive for cardiovascular disorders. His mother had a myocardial infarction at age 40 years, and his mother had a high cholesterol level, and his father cholesterol level was also high. And the physical and the patient's clinical data you can detect, and BMI suggested the patient has a first-degree obesity, and the total cholesterol, LDL cholesterol, fasting glucose level, and HbA1c level were high. And the physical examination, we can detect the tendon syntoma over the Achilles tendon. No, we cannot detect another physical abnormalities, and family history and laboratory research suggested maybe the patients had a familial hypercholesterolemia. Based on the incidence of data, the frequency of familial hypercholesterolemia in Hungary is between 20 to 40,000. As no such domestic survey has been conducted before, we use the data mining method to look at the frequency of familial hypercholesterolemia, those patients who hospitalized with definitive cardiovascular disorders. We use the Dutch criteria, the diagnosis of FH. As you can see, 225 patients score was between 2 and 6, and only 8 patients score was 8. And more than 20 person, 20 and the patients who has a familial hypercholesterolemia, 20% of the patients had a diabetes mellitus. And in this case, the patient's family history of early cardiovascular risk and tendon symptoma and the high cholesterol level suggested the patient has a familial hypercholesterolemia. And the patient has a diabetes mellitus also. Previous Norwegian study demonstrated the life expectancy, both gender, those patients who had a familial hypercholesterolemia reduced by 15 years. And another study demonstrated 25% of FH female patients and 50% of male patients had cardiovascular complications, and the risk of coronary disease was 3 to 16 times higher compared to the non-familial hypercholesteremic population, and the risk of peripheral arterial disease was 5 to 10 times higher compared to the general population. These data suggest that the patients who has a familial hypercholesterolemia represents the high-risk population. According to the European Atherosclerosis Society recommendation 2011, the familial hypercholesteremic children, the target LDL level less than 3.5 millimole per liter, adults less than 2.5 millimole per liter, and those others with cardiovascular disorders or diabetes less than 1.8 millimole per liter. Previous multi-center prospective study demonstrated if we reduce the LDL cholesterol level more than 1.8 millimole per liter, the clinical outcome will be better. According to these results, the newest European guideline suggested those patients who had a familial hypercholesterolemia and had a previous cardiovascular disorders or diabetes mellitus, these patients belong to the very high risk categories. In these categories, the target LDL level is 1.4 millimole per liter, and the initial LDL cholesterol level have to reduce more than 50%. If you want to reduce the risk factors of these patients, the first-line therapy is the lifestyle modification. The lifestyle modification only moderately reduces the LDL cholesterol level, and the lifestyle modification maybe reduce the weight of the patients and improve the blood glucose level of the patients. The second important step, the lipid-lowering therapy, we have to check the blood pressure of the patients and also have to normalize the blood glucose level of the patients and the antiplatelet therapy. These are reduce the cardiovascular risk in these patients. Today, I want to focus on the lipid-lowering therapy. In this case, the first-line lipid-lowering therapy is the statins. The statins inhibit the key enzyme of intercellular cholesterol synthesis, HMG cholereductase. In this way, increase the number on the surface of the cells, and a high amount of cholesterol bind to the LDL receptors, and the LDL receptors is taken off the cholesterol and markedly reduce the LDL cholesterol. Our country mainly used the rosuvastatin, atorvastatin, and simvastatin. As you can see, the statin can reduce the LDL cholesterol level between 30 to 60%. Previous study demonstrated if we use the intensive statin and moderately intensive statin, reduce the coronary heart disease and mortality by 44%. This study demonstrated the statin administration in this population significantly improved the clinical outcome of these patients. If we use the moderate statin reduced the LDL cholesterol level by 30%, high intensity statin reduced the LDL cholesterol level by 50%. During the statin administration, frequently about 5% we can detect the adverse event of the statin. Most common adverse event is a myopathy with or without CK level elevation, liver enzyme elevation, and the new onset of diabetes mellitus. The study in Japan demonstrated that atorvastatin is not increased the incidence of new onset diabetes, but another statin little bit increased the new onset diabetes. How can we avoid the side effect of statins? In case of side effect with the initial statin, switch to another alternative statin. Previous study demonstrated 92% of patients can tolerate the second statin, 72.5% of patients intolerate two statins due to myalgia can successfully tolerate the third statin. And another possibility is reduce the dose of the statins, and we use once or twice a week long-acting statin therapy. If we use the high-dose statin reduced 50% average of the LDL cholesterol level reduction. In these patients, the initial cholesterol level was 6.4 millimole per liter. 50% reduction of this LDL cholesterol represents 3.2 millimole per liter. The patients do not reach the LDL target. In this case, we have to use another lipid-lowering therapy. The most common statin combination therapy is the ezetimibe. The ezetimibe selectively inhibits the 9-unpick-like protein, which responsible the cholesterol resorption from the small intestine, and in this way reduced 80 to 21% the LDL cholesterol level. Previous study demonstrated the ezetimibe and statin co-administration significantly 24% reduced the risk of myocardial infarction and 39% reduced the ischemic stroke risk in diabetic subjects. And this study also demonstrated those patients who used ezetimibe more markedly reduced both the primary and secondary and tertiary endpoint compared to those patients without ezetimibe therapy. And another study demonstrated the ezetimibe improved the metabolic conditions, reduced the fasting blood glucose level, improved the insulin production, improved the insulin resistance, reduced the oxidative stress, and also reduced the inflammation, and also inhibit the smooth muscle cells proliferation and stabilize the plaque. That suggested the statin ezetimibe combination increased the LDL level, lead to further LDL reduction, and also has a beneficial metabolic effect. High intensity statin and ezetimibe combination lead to 65% LDL reduction. 55% LDL reduction in these patients is not enough to reach the LDL target. In this case, we can use another lipid-lowering agent, for example, PCSK9 inhibitors. As you can see, the PCSK9 inhibitors lead to 60% LDL reduction. PCSK9 inhibitors and high-intensity statin combination lead to 75% LDL reduction. PCSK9 inhibitors, high-intensity statin, and ezetimibe co-administration lead to 85% LDL reduction. 85 LDL reduction in these patients lead to 1 millimole LDL level, and in this case, the patients reach the LDL target. Previously demonstrated that patients who used the evolocumab, evolocumab reduced the LDL level both in non-diabetic and diabetic group patients group at similar level, and also demonstrated the evolocumab administration more markedly reduced the primary endpoint in diabetic patients group compared to the non-diabetic patients group. And another study evaluated the effect of aliricumab on the type 2 and type 1 diabetic patients, and these studies demonstrated the aliricumab significantly reduced the non-HDL level, ApoB100 level, and lipoprotein (LDL-C) level, and also demonstrated high percentage of patients with type 2 diabetes and type 1 diabetes reach the LDL target. And another study, Tashik Ray and co-workers studied the aliricumab effect of patients with diabetes, pre-diabetes, and normal glycemic subject, and they demonstrated the aliricumab reduced LDL cholesterol, non-HDL cholesterol, triglyceride level in each patient group, and similarly reduced the primary endpoint in both patients group, but more markedly reduced the absolute risk of the diabetic patients population. These studies demonstrated the PCSK9 inhibitor therapy useful if we want to reach the target level in this very high-risk population. Our country, the first-line therapy, those patients who has a familiar hypercholesterolemia is the statin, and the statin, if the patients do not reach the target LDL level after the high dose statin therapy, after then ezetimibe. If the patients do not reach the target level with statin and ezetimibe combination, after then we use the PCSK9 inhibitory therapy. This three combination is successful. High percentage of patients who has a familial hypercholesterolemia reach the LDL target, and in this way we can reduce the progression of atherosclerosis, and in this way we can prolong the survival rate, and we can improve the quality of the life of these patients. Thank you so much for your attention.
Thank you very much, Gyorgy. It was a beautiful presentation of the FH per patient. In fact, it is not so common to see such clear FH patients in our everyday clinical practice, because taking into account that we are in this statin therapy since 1994 and for a trial, these are not so common to see such beautiful Achilles tendon xanthomas. And so, and on the other hand, it is not. We need to remember that in all patients with FH, we might have also other concomitant disorders, in diseases including diabetes, and that is why we need to look at our patients in the comprehensive way, not only for FH but also for other concomitant diseases. So I believe it is very important issues to emphasize. Okay, but now it is my turn in order to present the case. Within my presentation, I would like to say a little bit more about a quite untypical case of patients with partial statin intolerance. In fact, in the end, I was not sure whether this patient had statin intolerance at all, because as you will see, those patients were very difficult in everyday clinic in an approach with the management, because he was anti-statin and he was in the end not willing to use statin therapy. This patient was referred to ambulatory clinics after discharge from the Department of Interventional Cardiology. And why he was referred? Because it was man at the age of 59, and he was admitted to this Department of Interventional Cardiology due to severe angina pain with the diagnosis of ACS. It was critical stenosis in LAD. Taking into account other risk factors, this man was with overweight, with BMI 27.6, with hypertension, which was treated with ramipril 5 milligrams per day, and it was quite good control of this hypertension. He was no smoking and no other major risk factors, including lipoprotein little a and other typical risk factors we usually evaluate. What about hypercholesterolemia? LDL cholesterol level at admission was 144 milligram per deciliter, total cholesterol 228, HDL was also lowered and the level was 38, and non-HDL 190. So we know it very well that these levels, taking into account his risk, which was very high, cardiovascular risk, these patients what after ACS, what not good, and the target should be below 55. After successful PCI, these patients received rosuvastatin 40 milligrams, which was good, taking into account the current guidelines, and finally to order to meet the target of LDL cholesterol below 55. But what was quite interesting, and I was asked to consult this patient, because after 48 hours, so quite early after initiation of the statin therapy, a patient started suffering severe and based on his report, intolerable pain, muscle pain of left calf and thigh and the back, which also next concerned right leg. So when we look at the SAMS score, it was 3 points, taking into account the early occurrence of the pain, and 3 points taking into account that there were symmetrical, typical pains associated with possible statin adverse effects. CK level, because I asked my colleagues in the department of the interventional cardiology to check the CK level, creatine kinase levels, was within the normal range, because it was 114. ALAT was also okay. Bilirubin, creatine, and other potential biomarkers, as you can see, were within normal values. Especially, I would like to put your attention to the level of the thyroid hormones, because we know very well that the thyroid hormones, especially hypothyroidism, might be associated with the increased risk of the statin intolerance, as well as vitamin D, which was also good. It was not so high level, but on the other hand, it was the level that wasn't suggested that it might be related to statin intolerance in the end. So. What is more, I also asked my colleagues from the Department of Interventional Cardiology to ask for the history of statin intolerance in the family, which was negative. However, in the end, what was quite interesting, taking into account his further approach to the therapy and the management with these very high risk patients, that the patients admitted that he's generally against statins, due to the information he received from Dr. Google, from internet, from his colleagues, and so on. And he knew from the very beginning that statins might be associated, taking into account his message, with large adverse effects, very critical adverse effects, liver and muscle damage, even which might be life-threatening conditions. And inconsistent opinion on the role of cholesterol on atherosclerosis and myocardial infarction. In the end, he admitted that he strongly believed that saturated fats might be protective against myocardial infarction and atherosclerosis. So it was very difficult at the very beginning to discuss with him about the role of statins, about that the statins might be protective against the recurrent cardiovascular events and might prolong his life, because he didn't believe in the mechanism of atherosclerosis at all. And finally, he admitted that irrespectively of the muscle pain, he would prefer not administering statin at all. And we started to believe that all those symptoms that at the very beginning we believed that were associated with the statin therapy might be associated with the so-called nocebo, or it is much more corrected placebo effect. Okay, but after consultation, rosuvastatin was changed to atorvastatin, and it was quite surprising that when the muscle pain, according to him, relieved, and in my opinion, it was mainly associated with the decrease of dose of statins, because he was very happy that the dose of statin was decreased and changed to another one, because it was changed to atorvastatin and ezetimibe. The pain was relieved after next 72 hours, and the patient was discharged at this dose of atorvastatin and ezetimibe, and with the levels of LDL cholesterol 129, the total cholesterol 217, and he was referred to the lipidologist. He was asked to visit me in next few weeks, and at the same time he was included in the Azouaou coordination care program of patients after acute coronary syndrome, when within the year those patients are treated, and within the time frame and the very detailed schedule of the visits in order to treat with the all the risk factors, and in order to have for these patients optimal therapy. After 6 weeks after he visit, after his discharge, during the visit in the cardiologist, he said he noticed and he told us that he is again he suffered from muscle pain, very untolerable muscle pain, a very large muscle pain, and that is why with the diagnosis of statin intolerance he was referred to my ambulatory clinic. So at the first visit, as you can see, he was at the dose which was during the discharge from the hospital, atorvastatin 20 milligrams and ezetimibe 10 milligram. And the LDL cholesterol level after those 6 weeks was quite nice, because it was 82 with non-HDL 127. CK was okay, so we weren't afraid that we are able or are forced to, in order to discontinue statin therapy. Triglycerides was a little bit over the range, which HDL cholesterol was within the level of normal. Because he suffered muscle pain, and we were not able to be sure that it is really not related to statin therapy, and it might be, for example, the placebo effect, because I discussed with these patients for many hours why it is important to continue statin therapy, why it is important for his health, why it might be preventable concerning the next risk factors. The patients agreed to continue rosuvastatin every second day, and I will tell you whether it is okay or not, taking into account the continuation of the maintaining the level of the LDL cholesterol, ezetimibe 10 milligrams. And after next few days or several days, because it was 10 days, the level of LDL cholesterol was 78, 125 was non-HDL. But on the third visit, he finally decided that he's completely fed up with statins, and he don't want to continue statin therapy. He's very tired with statin therapy, with changing of dose, of using statins, and especially from my point of view, it was related to his anti-statin approach and non-statin, and the belief that statins does not help. Statins do not help with the atherosclerosis prevention, and that is why he said he would like to be further treated in order to avoid next cardiovascular events, but without statins. That is why we decided to continue ezetimibe, because he was nothing against ezetimibe 10 milligrams, and I've decided to use Armolipid Plus. He's a nutraceuticals, which in fact has a monocolin K at the dose of 3 milligrams, so it is natural lovastatin, and he was informed obviously about this, but due to the fact that he heard that it is natural drug, natural products, he was nothing against the monocolin K, and that is why he agreed in order to have such a treatment. And in the fourth visit, as you can see, there was an increase of LDL cholesterol to 995 and non-HDL cholesterol to 135. Then I've decided to try to discuss him whether it is possible or not to use not only statin, but maybe a polypill with a very small dose of statin, because if he agreed to have a natural lovastatin at the dose of 3 milligram, I've decided to try to convince him to use another drug, which is the combination of two drugs. So it is not only a statin. I thought that it might be a good option, and I was so surprised that he said, okay, if it is not a statin at all, it is a combination of statin and ezetimibe with one tablets, and he will not be forced in order to use two tablets in his to treat hypercholesterolemia. Okay, he say, okay, he's nothing against in order to use a polypill with rosuvastatin 5 milligrams and ezetimibe 10 milligrams, and I've decided to continue Armolipid Plus taking into account his severe hypercholesterolemia, taking into account his very high cardiovascular risk. And as you can see, after 5 months, he was without any adverse effects, and in the end we finished with LDL cholesterol 64, which is still over the target, and non-HDL 104, which is still over the target. But the problem was that at the visit 3, as you can see, when he decided to discontinue statin therapy, I replied to the Polish Ministry of Health for the emergency use of PCSK9 inhibitors for these patients, but I received a negative opinion, and that is why in the end it was the only way in order to be on the target with these patients or close to the target, because we are not on the target with these patients. And that is why, what is more, as you can see, I am a little bit outside the guidelines, because there was no data in fact, and it is a kind of individualization therapy in order to be very close to the targets, because there is no data in order to use armolipids with natural atorvastatin with other statin in polypills, because we have especially data with armolipid with ezetimibe, and I will show you a little bit more about this. So you sometimes, from time to time, you need to be a little bit outside the guidelines. You need to be individualize your therapy in order to prevent your patients with recurrent cardiovascular events. Why it is important? First of all, it is very difficult to be very clear with the definition of statin intolerance. We know it very well that based on the different definitions and different guidelines and recommendations, it might be at least intolerance to at least 2 different statins, and it was in this case. And it might be elevation of the biomarkers, and it might be any statin-associated muscle symptoms, and in this situation it was really the statin-associated muscle symptoms. What is more, we know very well from the literature that it might be many different side effects after statin therapy, but you need to remember that the causality was confirmed only for muscle pain. The causality was confirmed for temporary elevation of alanine aminotransferase and for new onset diabetes. As for the alanine aminotransferase elevation, you need to remember that it is temporary, and in most of the cases we still might use statin therapy, because for all chronic liver diseases we should use statin therapy, because it might still prevent cardiovascular events and even might prevent the primary liver carcinoma. So it is very important. And what is more, it is probably one of the largest mistakes, because in most of the situation, most of the physicians decide to stop or discontinue statin therapy due to the elevation of the aminotransferase alanine. What is more, I would like to kindly invite you to use the statin-associated muscle symptoms clinical index score, because as you might have noticed from this case, I used it within the diagnosis of statin intolerance, which was very helpful. However, in the end, I still believe it was a placebo effect due to the approach of these patients to the antistatin to the statins, to the mechanism of atherosclerosis at all. What is more, finally, when you try to diagnose statin intolerance, you need to remember that almost 90% of symptoms occur within the first 3 to 6 months. What does it mean? It means that if you have symptoms after statin therapy, after few years of treatment with statins, it is very rare situation that it might be associated with statins. Besides the situation that you add any other drug, it might be drug-to-drug interaction, and it might be the worsening of the symptoms of, for example, of the liver disease, of the kidney disease, because we know it very well that chronic liver disease and chronic kidney disease might increase the risk of statin intolerance. Finally, placebo effect. Please remember about it. You probably remember the data from the ACORD lipid-lowering arm, ASCOT lipid-lowering arm trial, when it was confirmed that placebo effect really exists. What is more, you need to remember that for most of your patients with the CK level below 4, you still might continue statin therapy, and I am a little bit against the recommendation of the European Society of Cardiology and European Atherosclerosis Society that if you have your patients which is symptomatic with CK levels below 4, you need to completely discontinue statin therapy. You need to ask about the tolerability of this pain. You need to reduce the dose, but you still should monitor CK and try to continue statin therapy, because it is very helpful for the cardiovascular risk of those patients. What is more, you shouldn't wait with other kinds of treatment, lipid-lowering treatment, you still, when you discontinue statin therapy, for example, with CK levels over 4, you should start ezetimibe immediately, and you should consider, for example, nutraceuticals and PCSK9 inhibitors as only there are available, obviously. Why it is important? It is our data. It is very important due to the fact that we know that patients with not adherent to statin therapy, statin intolerance, are at a very high cardiovascular risk, and for those patients there is a higher risk in comparison to those who are adherent for next cardiovascular events and all-cause mortality. For taking into account this case, I would like to kindly also invite you, if your patient is not has statin intolerance, in order to try to use statins every second or even every third day, because we have data, and here you have our meta-analysis, that for rosuvastatin and atorvastatin, when you use every second, every third day, there is still very large reduction of the LDL cholesterol. It has been already mentioned, ezetimibe and the fixed combination ezetimibe with statin is critical, because we know it very well that this therapy, when we reduce the dose of statin and add ezetimibe, might be even more effective than the double the dose of statins. And finally, nutraceuticals. Probably it is the issue and something that needs to be further investigated, but we know it very well that there are at least several nutraceuticals with evidence base that might be used in statin intolerant patients, including radiestrise with monocolin K, and we have a data especially from Italy, from Giuseppe Rosano group, that in the connection with ezetimibe, this therapy might be effective. It might be associated with that for almost 70% of our patients. This might be on the target when we use ezetimibe with small dose of statins and nutraceuticals, on even only ezetimibe and nutraceuticals. And what is more, it is our meta-analysis, the largest one available, when we measure the role of the safety of radiestrise in patients with statin intolerance. As you can see, there is no safety signal. So we know it very well that this very low dose of natural lovastatin, which is usually 3 milligram, is very safe for our patients. So that's all. Taking into account my case, my apologies that I am a little bit 2 minutes late with my presentation. I should be on time to give a good example. But now for my colleagues and my friends, we have a quite nice surprise, because within the question and answers, we obviously will have time in order to have a question and answers, and in order to discuss, for example, the cases presented by Margus, Gustavs, and Gyorgy. But now I've asked all the participants from the previous webinars 1, 2, and 3 in order to send us their cases, and we have 4 cases to be presented by our colleague from Brazil. It is Professor Sergio Kaiser, from Algeria, from Croatia, and from Hungary. So we will start with Professor Sergio Kaiser. Sergio, very glad and happy you are with us. So thank you very much. So yes, the floor is yours, and I'm very looking forward to hearing your case. Sergio, please.
Okay. Good afternoon in Brazil and good evening in Europe. And thank you very much, Maciej and the International Lipid Expert Panel, for letting me join this very interesting clinical case session. And it's an interesting sequence because Maciej has just shown us a case where statin intolerance was questionable, but this patient is a truly resistant patient to statin. He's truly intolerant. So let me show you the first slide. This patient is now 65 years old, and he was seen by me for the first time in 2004. By that time, he was 51 years old. And he was referred to me by a colleague from São Paulo, where he had undergone stenting of the LAD artery. He got 2 sequential stents because of a positive radionuclide test. As you will see, he had a very good exercise tolerance, which by itself is a good prognostic. If he hadn't undergone radionuclide test, probably else. However, and he only had a 1 millimeter ST slope. I'm sorry for the HG, nothing to do with that. So he had a downsloping ST segment, and he was a heavy smoker. He used to smoke 1 pack a day for 25 years. He used to consume 1 bottle of wine a day for about 5 years. Sedentary. His father had died of a heart attack at the age of 66. And here is a radionuclide stress test. Let me show it to you. As you see, there was rather a 12% area of his left ventricle, which had a reversible perfusion defect. Curiously, his ejection fraction post-stress was reduced, which is not compatible with the excellent result of the treadmill test. But anyway, probably based on these findings, he got 2 stents. When he came to me, he already told me he was on 20 milligrams of atorvastatin a day, dual antiplatelet therapy, ramipril 5 milligrams a day, and atenolol 25 milligrams a day. And by that time, he decided to quit smoking. He never came back to my office until 4 years later. I don't know exactly why. Maybe he thought it was too young by that time. But the fact is, as he looked for 3 different cardiologists, all of them tried statins, I would say that his SAM score, okay, I'll calculate his SAM score, it was 10. Okay, he couldn't really tolerate. I myself tried several different schemes. I tried pitavastatin, alternate days, as Professor Banach had just shown in the previous presentation. And by that time, when he came back to the office, his cholesterol levels was 253 I'm sorry that I'm putting in milligrams per deciliter. He has a very high HDL level, and as we know now, very high HDL levels, they may be dysfunctional, and according to the work previously published by the Danish group, it might even be associated with higher mortality. His LDL was 123 milligrams per deciliter, and triglycerides were okay. So, I finally gave up trying the statins, so I left in with ezetimibe and I kept dual antiplatelet therapy, figuring out that, you know, since his LDL levels were not at goal, maybe I should keep the dual antiplatelet therapy, and he kept just on ezetimibe. Ever since, he used to undergo myocardial scintigraphy every year. He had always a very good performance. And by 2008, that's his laboratory. You can see by that time I requested an LPA. LPA was normal. He didn't have elevated CRP, by the way. It's not depicted here. And note that his HDL, very high, LDL, 104 milligrams per deciliter. So that was a 15% drop induced by ezetimibe. And in June 2016, he was complaining of a mild chest discomfort, sometimes related to effort, sometimes not very well characterized. But his myocardial radionuclide test, it shows it was stopped by exhaustion. He reached 9 METs, but there was indeed another perfusion defect, a 12% defect, and his stress ejection fraction was normal. So you can see here in the bullseye vision there was a defect. So my decision was to request immediately a coronary arteriography. And here is the result. Here. Okay. And from his arteriography, you can see that he has a very severe and irregular lesion here in proximal LAD. There was another lesion in the mid-segment of his LAD between the two previously implanted stents. You can also see that there is a non-obstructive long lesion in his right coronary artery. So he got two everolimus stents, one in proximal LAD, another mid-LAD between these two stents with a very good post-stenting result. Okay, so then I tried everything I could. Dual antiplatelet therapy, of course, cholestyramine, ezetimibe, phytosterols, everything I could could be reachable in order to try to get him to lower his blood cholesterol. Luckily, fortunately, 2 months later, evolocumab came to Brazilian market. It was launched in Brazil, and I started him on evolocumab, 140 milligrams every 2 weeks. Okay, and I decided to discontinue the other lipid-lowering therapies, except, of course, for ezetimibe. And this is his final results. His LDL dropped 62%. I consider that he reached the goals because if he his desired goal wouldn't be 1.4 millimoles per 1.0 millimoles per liter, but rather 1.4, because he actually never had a previous heart attack. He was stented without any heart attack. So I considered his goal was 1.4. So that was 69 milligrams per 48 milligrams per deciliter of LDL, which I considered very satisfactory. The patient has doing fine ever since. And the conclusions, there's not a take-home message, but I think that the messages that were issued by Professor Latkovskis and Professor Banach regarding his first case from Professor Latkovskis and his statin intolerance case from the last presentation, they are very well fitted to this case. So thank you very much. It's open for discussion if you wish.
Thank you very much, Sergio. To say it was a beautiful presentation and beautiful case. In fact, I would like to suggest that there will be 2 comments from our experts, if there are any, in order to discuss this case, because it was quite spectacular case, taking into account the patients with true statin intolerance. So Gustavs, maybe a voice from you, and I will add a little bit, and we will go for another case.
Yes, it's a very interesting case, and really nicely illustrates that there are some patients with whom it's very difficult to get to the low goals, and we also have tried sometimes various methods and gradual increasing doses, and then trying to use the bile acid secrestins, etc. And it's really very challenging. So PCSK9 inhibitors are really very helpful in these situations. I think it's also very interesting that this patient had very high HDL cholesterol. I just calculated somewhere around 3 millimoles per liter according to our measurement units. So I think it's really just points out and stresses that HDL really well above let's say above 2 is not really protective in many cases and may even be additional risk factor. It's
okay,
case.
I believe that. Thank you, Gustavs. I believe you just touched the most important issue. First of all, I also wanted to add a little bit to the very high HDL cholesterol in these patients, because for most of the physicians worldwide, they still believe that very high HDL cholesterol might be protective. It is not true any longer, because we know very well that we have concomitant risk factors, including atherosclerotic cardiovascular disease and high level of inflammation, because it is always very associated and linked. Most of the HDL particles are dysfunctional, and I believe based on the data from Danish group Sergio mentioned, but also based on the data we publish in European Heart Journal based on the REGARDS study, we noticed that when we have an enhanced study in the International Journal of Cardiology, we noticed that very high level, especially over 80 and especially over 100, might be associated with the high level of inflammation, increased risk of cardiovascular events, and the risk of cancer, in fact. So it is something that needs to be further investigated because it is something that is very, very difficult. Sergio, one question. Why you did not continue phytosterols in your patient and why you stopped phytosterols? Because it is something that I believe it is not a drug-to-drug interaction with evolocumab, ezetimibe, and phytosterols. So why you have decided to stop phytosterols? It is just a question.
Yeah, sure. Because he was complaining that he was taking too many medications. That's why. And actually, since he was at goal, I wasn't really worried about that. But can I add 2 other comments? Do I have time for 2 other comments? Quick, very quick. First of all, one thing that I forgot, it's not a protocol to have a troponin I measurements before an angiography. It's an elective angiography. But actually, I decided to ask for a troponin I, and it was above the 99th percentile. So this patient apparently was starting to develop acute coronary syndrome. He was very lucky to be catheterized that day. And the second thing that I would like to point out, his daughter is 37 years old. She's also my patient, and her calcium score is 110. So probably what they have, they probably have a high genetic risk score, which we can look for it here in Brazil because we don't have data.
I believe it is
very If I may add to that.
Yeah, Gustavs, we have 3 other cases, and I'm a little bit afraid, but yes, please, go ahead.
So let's go on. Yeah.
No, please go ahead.
Just brief comment that regarding the troponin, it has been also described that in patients with a chronic coronary heart disease, with the severe lesions or diffuse disease, they also may have chronically mildly elevated troponin levels. So it would be interesting to see what was the delta, the dynamics of those troponins if they had been measured.
Okay, my final comment is that I promise you all that the next webinar will be dedicated to polygenic risk score, because I believe it is something that needs to be further presented and we all should be educated, because, for example, in Poland, we do it very rare as it is similar to the lipoprotein(a) management. So I believe it is so important, especially in the primary, but also in the secondary prevention, in order to be sure that risk stratification of our patients is correct. And probably it is also related to this, his daughter, 37-year-old, which was normally probably low to moderate risk, but due to the polygenic risk score, she was, and CAC score especially, she was stratified as very high cardiovascular risk. Okay, we need to go to the second case, and it will be the case series, and it is my great pleasure to invite Dr. Leila Azouaou. My apologies if my pronunciation is not correct. We have this presentation, and okay, so let's start. It will be something that we usually missed in our webinars, but I believe it is very important. So it is the patient's case series with patients with chronic kidney disease. So yes, please, the floor is yours. Thank you very much. You are with us.
Thank you. Ladies and gentlemen, good afternoon. Excuse my accent. I am a francophone person. Je vais essayer de vous présenter le travail en anglais. Let me introduce myself. I am Professor Azouaou Leila in nephrology of the Hussein Hospital in Algiers. The work I will present today is titled Lipid Disorders in Patients with Chronic Renal Failure. In introduction, lipid disorders represent one of the risk factors for cardiovascular complications and mortality in patients with chronic renal failure, and especially hemodialysis. The aim of this work is to determine the metabolic disorders in patients with chronic renal failure at different stages. In material admits a descriptive longitudinal study which prospective collection has been conducted on 162 patients. All CKD patients were blood sampled for measuring lipid markers. We included in the study all CKD patients over the age of 80 of various etiologies and at different stages of development. CKD patients were categorized into 5 groups according to the kidney disease and proving global. Briefly, stage 2 included 31 patients, stage 3 included 41 patients, stage 4 included 31 patients with severe CKD symptoms, and stage 5 regrouped as 27 patients, and we received 32 patients in hemodialysis. The sex ratio of the study is 1.41, the average age is 56. In our study, we found significant linear increases in the mean of triglyceride values according to the different stage of CKD. The lowest value is seen in the stage 2 patient, and the highest rate is seen in stage 5D patient, while cholesterol level and HDL cholesterol with the deterioration of renal function and P is significant. It's clear that lipid disorders worsen with the deterioration of renal function. In discussion, I remind you that in the metabolism of lipids at the heart of chronic renal failure, there is a disturbance of 2 enzymes, lipoprotein lipase, which will lead to an increase in the LDL and therefore triglycerides, and the second enzyme, which lecithin cholesterol acetyltransferase, which will disrupt the recycling of HDL and the return of cholesterol to liver, and the consequences are the bypass of cholesterol and HDL cholesterol. In the first study in American MAG by Koppel, it is prospective randomized study made on 55 patients, or they found our cholesterol decrease with the decrease in renal function, which coincides with our study. While the second English study made by Leila, which to find that the triglycerides in patients with chronic renal failure are higher than the healthy people, and the difference is significant, while HDL cholesterol is lower, which agrees with our results. In conclusion, in our work, we have certainly found an increase in triglyceride values with the deterioration of renal function, and concluded that in this population, we speak rather of dyslipidemia than hyperlipidemia. Cholesterol values tend to decrease in relation to undernutrition, which is sometimes instilled by the entourage of the patient and even by the lack of consultation of nutritionists for re-education food. And thank you for your attention.
Thank you very much for this very interesting presentation, especially that, as I've mentioned, we haven't had the opportunity to discuss the issue of the lipid-lowering therapy in patients with chronic kidney disease within these webinars. And we remember that there are many physicians that still do not know what to do, especially in the end-stage renal disease. And we need to remember that the baseline therapy, baseline condition, if we have a MI patients with end-stage renal disease, we still should continue statins, because MI is important, more important, and the prevention of the recurrent events is the more important for us. It is important also to know that in your presentation, we should remember that we should expect a kind of dyslipidemia linked to chronic kidney disease. One important thing to remember that we should also in those patients, we might also expect in those patients lipoprotein little a increase, because in chronic kidney disease, lipoprotein little a might be also increased. It is something that we should also have in mind. So thank you very much once again for beautiful presentation, and congratulations and best wishes. We send best wishes to Algeria, and thank you for your beautiful French English, which was very great to hear for us. Thank you very much. And because we have a little bit out of time, let's please, I would like to kindly welcome Professor Istvan Pećin from Croatia. Ivan, it is very good that you are with us again. So the floor is yours. We have been waiting for a spectacular case, and taking into account I know you well, I am very sure it will be a spectacular case. So Ivan, let's start.
Dear Maciej, dear colleagues, dear ladies and gentlemen, good evening. Well, indeed, it's a really pleasure to be here again with you. And I would like to take the second opinion of you. And Maciej, I would like to congratulate you because I heard there are 700 participants. So should I call it second opinion at the end or 700 opinions? You will see. So I called my presentation FH and LP(a) the end, or is it the end, or it could be the end? You will see. So this is a young patient, age 21, when I recognized him. He was admitted, as you can see here in Zagreb, at the Department of Cardiology because of the signs of unstable angina and pathological ECG finding, as you can see here. So urgent intervention was performed and the PCI stent was placed. So his anamnesis goes that at the age of 10, he collapsed 2 times without going to his pediatrician, And then after that, when he was 12, because of the learning problems in the school, the EEG was made and the indication for the brain MRI was also indicated. And the brain MRI showed the mollustic lesion 4 by 3 centimeters, as you can see here. And then pediatrician performed lipid levels because of the positive family history. And this is his lipid levels. As you can see here, LDL cholesterol is 9.6 millimoles per liter. So he started with simvastatin only 10 milligrams at this point. And when 6 years after, when he became 18, he stopped on his own the therapy. So although he knew about this lipidemia, he wasn't compliant, as you also saw from other cases. He smoked, as is presented here. He was overweight and he performed sedentary lifestyle. So at the time when we got him with acute coronary syndrome, look at his lab results. So without therapy, LDL cholesterol 10.9, as you can see here. So the story goes on. The family history was quite positive for an early cardiovascular events, as you can see here. You would appreciate that the grandfather died when he was 27 out of heart attack, and mother knew about complex dyslipidemia. So this is her LDL cholesterol level with maximum tolerated statin and ezetimibe, that means Rosova 40 and ezetimibe 10. And his sister also has, as you can see here, with Rosova 40 and ezetimibe 10, LDL cholesterol 4.1. Thanks to the pilot program with Professor Steve Humphries in the University, in the Center for Cardiovascular Genetics, University College of London, we performed the genetic analysis and we found a novel mutation. So it was for the first time described in whole family, as you can see here, but one son wasn't affected. So we also managed to publish this several years ago, so you can find it on the internet. Of course, he was put on the maximum tolerated statin. It was rosuvastatin 40 milligram and ezetimibe 10 milligrams. He still smokes. So after this therapy, after 2 months, his LDL cholesterol value was, as you can see here, 4.79. And we couldn't go lower but we should go lower according to the novel guidelines and the new guidelines, below 1.4 millimoles per liter. And then about 2 years ago, PCSK9 inhibition became available and reimbursed in Croatia. So he was put on top of the maximum tolerated statin and ezetimibe on alirocumab 150 milligrams every other 2 times a month. And as you can see here, his first lab result after 3 months after PCSK9 inhibition on top of statin and ezetimibe. But I was wondering, so he's now on goal, but why his grandfather died out of myocardial infarction such young, and why he had stroke also such young, our case index patient? So we performed lipoprotein Lp(a), and as you can see here, those are the nanomoles per liter, 238 nanomoles per liter, but this was after the PCSK9 inhibition, so it was about 30% higher at the first finding. So I need a second opinion. What is the next approach for my patient? So I was very pleased that we finally reached target LDL cholesterol values, but we still have, as you can see here, high Lp(a). So please do advise, should we continue on top this Lp(a) apheresis? And just as an information, 4 years ago, he became a father. And we screened also a daughter. As you can see here, she has LDL cholesterol 4.7, so she's also FH, and we are still waiting Lp(a) level. So please do advise. Thank you very much.
Thank you, Ivan. It was, as you have promised, it was a spectacular case. And I don't know, Margus, maybe you would like to comment it, or any other experts from our group?
Yeah.
Yes, please, because polygenic
It's
stroke
pleasure. Thank you.
risks.
Yeah, really, I'm very happy to see that LDL cholesterol is well treated. But what about lipoprotein small a? Sure, PCSK9 inhibitors decrease lipoprotein small a by 30 to 40%. But I think it's quite substantial. But there are new drugs coming up with, they are now in the second and third phase of clinical trials, which can decrease lipoprotein small a 90%, 85%, and we have to wait a little bit. And of course, apheresis is also an option, but maybe as a last option. So that's my opinion.
Okay, Gustavs, Gyorgy, maybe you would like to add something? Mm-hmm.
I would probably have a quite similar response. Of course, we are looking forward to the results of Ionis apoprotein Lp(a) antisense therapy, but the results of this clinical outcome trial, I think, are going to be only available maybe in 2 years or so. Meanwhile, well, in Latvia, unfortunately, we do not have even LDL apheresis, so that would not be possible to do also lipoprotein Lp(a) apheresis. Well, we know that niacin is able to decrease the lipoprotein Lp(a). Does that transfer into clinical benefit? We are not sure, but probably this is the only thing that we can consider, because since this patient is already for secondary prevention, he already receives the aspirin, which also may be of some benefit. So otherwise, I wouldn't see much that we can do currently about it. Apart from, I would of course check his thyroid function just to be sure it's not hypothyroidism. That also may sometimes a little bit facilitate. These are my guesses.
Yeah, thank you. I believe that
maybe just one more comment. As I started LDL apheresis some 25 years ago in Estonia, and we're still doing it. Also, Lp(a) apheresis. I'm still not so happy about it. It's just some cases, and this is not very convenient for the patient. And of course, the results are good, but it's very, very cumbersome procedure, really.
Yeah. Gyorgy,
I agree with you. The lipoprotein level elevation increased the risk. But another question, as I understand, the patients follow the smoking. It's very important, the smoking cessation in this case, if you want to reduce another risk of the patient. Because in this case, you use a new method to reduce the lipoprotein level, but the patients maintain the smoking cessation. It's very important to reduce have to stop the smoking in this case.
I believe it is a very important comment because truly we should look for the general risk of our patients. So for all the risk factors, it is one thing. Second thing is, Ivan, you probably also having many patients, you've noticed that where you have a genetic predisposition for one disease, it is more common chance in order to have a genetic predisposition for another one. So I'm not surprised that in these patients there is a high level of lipoprotein(a) because in patients with FH, in fact, we might observe, for example, in 30 to 40% very high levels of lipoprotein(a). The third thing, I believe that for niacin, it is very good suggestion by Gustavs, but in the end, niacin might reduce lipoprotein(a) by about 25 to 30% with large adverse effects. And in these patients, when we have a 228, as far as I remember, it wouldn't be much better after the niacin. So I believe, and for example, I try to do it my best in case of such patients. For example, because Horizon lipoprotein(a) trial with antisense therapy against lipoprotein(a) I have in my department, I usually try to include these patients within the randomized control trial. Because it is the only chance in order to be effective in these very complicated case. So I also believe that some of you, if you have trials in your departments and patients which is very complicated, meet the inclusion criteria, it is another option we should remember, try to help our patients as only obviously he agrees to be included in the end, right? Okay, Ivan,
okay,
thank you very much.
Thank you very much.
Yes, please, Gustavs, yes, because you wanted to add something. Mm-hmm.
Yeah, I would like to put forward the one theoretical question. Let's assume the antisense therapy of this Ionis, the agent is really comes out positive. So what would you do? You would switch patient from PCSK9 inhibitor to this one, or you just use it as add-on?
It is very hypothetical question, but on the other hand, if you look at the inclusion criteria, take into account the different randomized controlled trials with antisense therapy, there is no contraindication to be on PCSK9 inhibitors in order to start antisense therapy. That is why it is still possible to combine all those drugs. Okay, Ivan, thank you very much. We send you the warm wishes to Croatia. So let's be in touch. Thank you very much. And let's move to the last case from Dr. Istvan Reiber from Hungary. So hello, Dr. Reiber. It is a great pleasure to have you here. So the floor is yours in order to present the most important, this very spectacular case from your clinical practice. Thank you.
Yes. Good evening, Professor Banach and dear colleagues. It is a great pleasure to participate in this important webinar. What I will to show today is a short case. This is a this is a 59 years old woman. Oh, sorry. She has hypertension, dyslipidemia, and not only higher LDL level, but hyper LDL-C, more than 5 times higher as upper normal level. Type 2 diabetes, smoking, and after stomachectomy, normal hormones, thyroid hormones. And 2018, in November, she had acute coronary syndrome, MI, and then PCI and stenting. And 2019, in January, we show in the carotid area 60% stenosis. And during the coronarography, 2019 March, we see 70% stenosis, the process progression. The therapy is the usual: prasugrel, aspirin, beta blocker, ECA inhibition, and sure, lipid-lowering therapy, but that was not always. We see in 2014, without lipid therapy, she had 4.18 millimole per liter LDL cholesterol, 160 milligram per deciliter. And after myocardial infarction, she got atorvastatin 80 milligram, what is recommended. And she had then 3.33 millimole per liter LDL cholesterol, and when is not enough, not the target, combined with ezetimibe 10, atorvastatin 80 milligram, we achieved 2.76 millimole per liter, 106 milligram per deciliter. And why the possibility is given today, we combined atorvastatin 80 and plus ezetimibe 10 with PCSK9 inhibition in every 2 weeks, 75 milligram eliquimab. And then we had in this year, in March, before the COVID attack, 1.4 millimole per liter, 55 milligram per deciliter LDL cholesterol. It's very good. But the next question, I showed before, direct LDL cholesterol. This is a homogeneous technique measured, not the gold standard UC, the ultracentrifugation, but anyway, is a laboratory measured. But in Hungary, and I think is many other countries, it's not for everywhere and everyone is possible to have direct LDL cholesterol level to know, and it is recommended since 1972. When we have total cholesterol, HDL cholesterol, and TG, then we use Friedewald equation, and then we have LDL cholesterol. What we see here, that's the difference between direct LDL cholesterol and Friedewald LDL cholesterol. In this case, when the patient have low LDL cholesterol and a little bit higher TG, this was more than 2.0 millimole per liter, then the difference is nearly 1 millimole per liter. But fortunately, we have the new equation, this Martin Hopkins equation. This is very easy. We have mobile and PC application. This is a modified Friedewald formula. This is the important. This is not the fixed 2.2 for TG divided. This is one factor. This is dependent from TG and non-HDL, and this is certificated with UC determined LDL cholesterol. And what is a clear message from this case? The using the high intensity statin early as a possible from begin we need it, and using the combination, the lipid-lowering therapy, when we have high intensity statin, then we have not the target for LDL, then we need ezetimibe and we need PCSK9 inhibition and use the appropriate LDL cholesterol determination for the target value. Thank you for your attention.
Thank you very much, Dr. Reiber, for a beautiful presentation. I believe you have raised a very important issue on how to correctly measure LDL cholesterol? Because we know it very well that the Friedewald formula is not so good. It is much more recommended to use the direct LDL measurement, and for example, in case of very low levels of LDL cholesterol, to consider non-HDL, but also the Martin Hopkins formula. I know Seth Martin very well from John Hopkins Hospital, and I was involved in some of his studies on the Martin Hopkins formula, might be also very, very useful. What is your experience, Gustavs, Margus, Gyorgy, on the use of other measurements than Friedewald, direct, Martin Hopkins? Maybe you sometimes consider, based on the recommendation, non-HDL, ApoB, if you have some doubts that the measurement of LDL might not be correct. Gustavs, Margus, do you have an opinion on it, on this?
Well, our main laboratory that where patients are referred to, they usually use the direct method, so we usually stick to that. But on the other hand, I think in many cases the real problem is that the LDL levels are anyway too high, whichever method you use. So the main problem is to have it below 1.4 and this question becomes clinically relevant in not that many cases. So that's my take on it.
I would like
also I can say the same, that we should use the direct method, and that the discussion was some 15-20 years ago, and to compare different formulas, but now it's time for direct. Even there's a direct method, there are some differences between different devices, but we should use the direct. Absolutely.
I totally agree.
I also can add that I think it's
Yes, please, Gustav.
I think it's very important also that we focus not only on LDL cholesterol, but also on non-HDL. And I think sometimes people forget this, that the non-HDL cholesterol goal should be 0.8 millimoles per liter higher than that of LDL cholesterol. So sometimes some people, well, especially if the triglycerides are high and or HDL cholesterol is low. So we focus more on that. But this was very interesting presentation actually, and I just several weeks ago I raised this question that we should investigate that in our patients. How would these formula behave, and how does that compare to the direct LDL cholesterol in our HeFH patient population across different kind of levels? So just to understand it.
Okay. Final comment on this beautiful case that, for example, in the Polish very current guidelines of the Polish Society of Diagnostics and Polish Lipid Associations that was presented in January this year, we highly recommended Martin Hopkins formula because we also validated it in the lipidogram cohort study in Poland based on the 50,000 patients. And we know it very well that it might be much more predictable, much more accurate in patients with very low levels of LDL cholesterol, even very high levels of LDL cholesterol. And I also agree, for example, in Poland, it is quite typical that for all measurements we have for the lipid profile, we have non-HDL, because non-HDL is critical if we have atherogenic dyslipidemia, if we have obesity, we have diabetes and metabolic syndrome and so on, because it really presents the risk of the patients, taking into account the accumulation of the triglycerides, because it is not only LDL but also IDL, VLDL, and chylomicron. So I believe it is very important to remember about the non-HDL. Okay, we have because we are much out of time. Dr. Reiber, thank you very much. I would like also to answer two questions very briefly. Is there any difference in myalgia or side effects or resistance between hydrophilic and lipophilic statins? I believe it is quite, we discussed it so many times, and we know it very well that hydrophilic statins such as rosuvastatin and pravastatin are much better tolerable, because the level of adverse events after rosuvastatin is about 6.4%, and for example after atorvastatin 12 and simvastatin 14 to 15. So altogether, for example, in elderly patients, it is a kind of brief recommendation in order to consider rosuvastatin rather than atorvastatin and simvastatin, due to the fact that there is completely different pharmacodynamics. And there is also a question to Sergio, I believe, but Sergio has already answered it, from Maciej. about the family testing for genetic risk of these patients that Sergio presented, but he also mentioned that his daughter, the daughter of the patient he presented, is under his care, and he was already evaluated and diagnosed at the age of 37. So I believe it is an answer for this question. But the last questions I would like to ask you, maybe Gustavs or Margus, it is the question 2. Do you recommend evolocumab for patients with high LDL more than other parameters like the triglycerides or VLDL? So another way, the question is whether PCSK9 inhibitors might also be associated with a significant reduction of triglycerides or maybe VLDL or other lipid parameters. So what is your opinion about this? I believe it is, for me, it is less important because I simply would like to have PCSK9 inhibitors for my all very high and extremely high risk patients. It is the most important issue for me, but I would like also ask you to try to respond, especially probably take into account triglycerides level, whether it is important or not. Margus, maybe, or Gustav, sorry.
Yeah, it's the most important is the PCSK9 inhibitor. Of course, is LDL additional huge LDL decrease and also lipoprotein small a decrease. There is no big issue with the triglycerides in this.
Okay.
Of course, the triglycerides are important. We are missing, actually, what is the problem? We are missing the proper drug for triglycerides. That's a problem in clinical practice, and I do hope that we are getting the same powerful drug like PCSK9 is for LDL.
I do believe, that we will be finally able, because we have been still working on it, to present the secondary dyslipidemia management guidelines by International Lipid Expert Panel, because it is something that Margus has just mentioned, that sometimes we forget how to treat secondary dyslipidemias, because it is the very important issue, especially when we have a severe hypertriglyceridemia, because for most of those patients, hypertriglyceridemia is associated with the secondary causes, in fact, from the everyday clinical practice. But okay, I believe we are 26 minutes out of time, and thank you very yes, Gustavs. Yes, please.
No, just a brief comment. I think if the triglycerides are mildly elevated, our focus should always be to reduce the ApoB-containing particles. So the PCSK9 inhibitor, of course, is very important. If triglycerides are really very dominating over the cholesterol level, I think fibrates sometimes can be used. Of course, not speaking about the very, very severe hypertriglyceridemias, where in future probably anti-ApoC3 we could be using.
And obviously, we have been waiting for new highly purified eicosapentaenoic acid in order to be available in Europe.
As well.
I'm looking forward to having the opportunity to treat my severe hypertriglyceridemic patients with Vascepa. Okay. I would like to kindly thank you to all the participants.
Only in the United States and Canada.
Yeah, sure. And I would like to kindly thank you.
As far as I know, only United States and Canada.
Yeah, okay. If these are all the voices and messages and comments, I would like to kindly thank you to all the participants, because there are over 700 participants from all over the world, from Algeria, Saudi Arabia, Europe, Canada, US, Japan, China, and many others. So it is a great pleasure for all of us, for the International Lipid Expert Panel, that you are with us. Hopefully, those cases and all those discussions will be very useful for you in your everyday clinical practice. We are also able to answer all your questions if we were not able to do it within this webinar. So please send us via email, via any other way of communication in order to help you with this question. I also would like to promise that it is not the last webinar of the International Lipid Expert Panel, because we have just received the confirmation that we will start in September, at the very beginning of September, with the next series of webinars. It will be a kind of surprise, taking into account especially the topic of this webinar. So please I will inform you all, we will all inform you, because here we are all the experts of the International Lipid Expert Panel about the topic in next few weeks. So thank you very much. I would like to again kindly thank you to my old friends, Professor Margus Viigima from Tallinn, Estonia, Professor Gustavs Latkovskis from Riga, from Latvia, and Professor Gyorgy Paragh from Debrecen, from Hungary. And I would like kindly thank you to our friends and partners from Amgen and Sanofi, because without them it wouldn't be possible to organize those meetings. And I am very glad that pharmaceutical companies are also involved in the continuing education of physicians who take care of the patients with lipid disorders. So thank you very much. Have a very good evening, have a very good weekend, and see you soon. Thank you very much.